Welcome to today's session on parasitic infections of the hematopoietic and lymphoid systems, focusing on malaria and leishmaniasis. By the end of this lecture, you should be able to list the general characteristics of Plasmodium and Leishmania, describe their morphology and life cycles with modes of transmission, explain the pathogenesis of malaria, discuss laboratory diagnostic methods, and outline prevention and control measures for both diseases. Today's case: a 26-year-old businessman, otherwise healthy, walks into his GP's office just 1 week after returning from Cambodia. He presents with an abrupt onset of bouts of shivering and feeling cold, accompanied by vomiting, rigors, and profuse sweating. He also complains of headache and nausea. Now let's pause. A young adult, recent travel, acute cyclical fevers with rigors, nausea, and systemic symptoms? In medicine, we call this a classic presentation. This screams malaria. And the clue that seals it? A peripheral blood smear reveals multiple ring-shaped parasites inside small red blood cells. That's the fingerprint of Plasmodium falciparum, the deadliest malaria species. Unlike other Plasmodium types, P. falciparum infects red blood cells of all ages, often showing high parasite loads and multiple rings per cell. Critically, it can cause infected RBCs to stick to blood vessel walls, leading to organ damage, cerebral malaria, or even death if untreated. Cambodia sits in the known hotspot for drug-resistant P. falciparum. That makes prompt diagnosis and correct treatment not just urgent, but life-saving. This case reminds us: fever in a returning traveler is malaria until proven otherwise. Even if they took prophylaxis or think they didn't get bitten. Mosquitoes don't ask permission. Always ask, "Where have you traveled?" And when the answer includes a malaria endemic zone, think fast, test immediately, and treat aggressively. Because in malaria, hours matter. Plasmodium is a unicellular parasite that specifically infects red blood cells. These organisms belong to a group called coccidian or sporozoan parasites, characterized by having no organelles of locomotion. 5 species of Plasmodium infect humans, and they all share a common, complex life cycle. Humans acquire malaria primarily through the bite of infected female Anopheles mosquitoes, though transfusion-related transmission can also occur. Understanding the life cycle is crucial. Plasmodium requires 2 hosts. Mosquitoes serve as the definitive host where sexual reproductive stages occur, while humans are the intermediate host, where asexual reproductive stages take place. 5 species of Plasmodium cause human malaria. Plasmodium vivax and Plasmodium falciparum are the most common globally. Plasmodium ovale and Plasmodium malaria are less frequently encountered. The 5th species, Plasmodium knowlesi, is actually a simian parasite that has recently emerged as a cause of human infection, particularly in Southeast Asia. Each species has distinct characteristics in terms of severity, relapse patterns, and geographic distribution, which we'll explore further. Within red blood cells, Plasmodium exists in several morphological forms that are crucial for diagnosis. The ring stage, or younger trophozoites, are the earliest forms you'll see. As parasites mature, they develop into older trophozoites with more visible cytoplasm and pigment. Schizonts represent the late stage where the parasite divides into multiple merozoites. Finally, there are the sexual forms: macrogametocytes, which are female, and microgametocytes, which are male. Recognizing these different forms in blood smears is essential for species identification and diagnosis. Let me elaborate on the 4 key developmental stages. The ring stage is the early asexual erythrocytic parasite, often arranged in a ring shape around a central vacuole. This is what you'll most commonly see in blood smears. The trophozoite is the next stage, where the parasite loses its ring appearance and begins to accumulate hemozoan pigment from digested hemoglobin. The schizont is the late developmental stage, where the parasite divides into multiple merozoites, characterized by the presence of multiple contiguous chromatin dots. This looks like a cell packed with nuclei. Finally, gametocytes are the sexual erythrocytic stages. The macrogametocyte is female, and the microgametocyte is male. These sexual forms are taken up by mosquitoes to continue the life cycle. This image shows a characteristic feature of Plasmodium falciparum infection: multiple ring forms within a single red blood cell. While other Plasmodium species typically show only 1 parasite per erythrocyte, P. falciparum commonly infects red blood cells with 2 or more rings. This finding is highly suggestive of falciparum malaria and is an important diagnostic clue. The ability of P. falciparum to multiply extensively and infect multiple cells simultaneously contributes to the high parasitemia and severity of this species. Here we see the distinctive gametocytes of Plasmodium falciparum in a peripheral blood smear. Notice their characteristic banana or crescent shape. This is pathognomonic for P. falciparum and distinguishes it from all other Plasmodium species, which have round or oval gametocytes. These sexual forms persist in the blood for up to 22 days and are the forms taken up by mosquitoes during blood meals, allowing transmission to continue. Identifying these crescent-shaped gametocytes confirms falciparum malaria. This image demonstrates another characteristic feature of Plasmodium falciparum, called acole-forms or applique-forms. Notice how the parasites appear to be applied to the margin of the red blood cell, like a signet ring pressed against the cell membrane. This occurs because falciparum-infected erythrocytes lose their deformability, and the parasites tend to flatten against the cell wall. This finding, along with multiple rings and crescent gametocytes, helps confirm P. falciparum infection. This peripheral blood smear shows the ring stage of Plasmodium vivax. Notice the red blood cell is enlarged compared to normal erythrocytes. This is characteristic of P. vivax, which preferentially infects young red blood cells or reticulocytes. The ring form itself is larger and has more cytoplasm than falciparum rings. P. vivax infected cells often show Schuffner's dots, which are fine pink granules throughout the cytoplasm, though they may not be visible in early ring stages. These morphological features help distinguish P. vivax from other species. The Plasmodium life cycle occurs in two distinct phases across two hosts. The asexual phase takes place in humans, who serve as the intermediate host. The sexual phase occurs in female anopheline mosquitoes, which are the definitive host. Understanding this complete cycle is essential, because it explains the pathogenesis, clinical features, and provides targets for prevention and treatment. The cycle involves multiple stages of reproduction and transformation between these two hosts. The Plasmodium life cycle occurs in two distinct phases across two hosts. The asexual phase takes place in humans, who serve as the intermediate host. The sexual phase occurs in female anopheline mosquitoes, which are the definitive host. This diagram illustrates the complete life cycle of Plasmodium. Follow the cycle. It begins with an infected mosquito injecting sporozoites during a blood meal. These sporozoites travel to the liver for the exoerythrocytic cycle. Then merozoites are released into blood to infect red blood cells for the erythrocytic cycle. Some parasites develop into gametocytes, which are taken up by mosquitoes. In the mosquito, sexual reproduction occurs, eventually producing sporozoites that migrate to salivary glands, ready to infect the next human host. This complex cycle explains the incubation period, fever patterns, and transmission dynamics. Let's explore the exoerythrocytic cycle in detail. Humans are infected through the bite of an infected female Anopheles mosquito that inoculates spindle-shaped sporozoites into the bloodstream or deep skin layers. Remarkably, only a small number of sporozoites are needed to cause infection, as few as 10 for P. falciparum. Within 15 to 45 minutes of inoculation, sporozoites of all Plasmodium species reach the liver through the bloodstream and infect hepatocytes. Inside liver cells, asexual multiplication takes place. The sporozoite develops into a large, multinuclear structure called a tissue schizont, or meront. This liver stage is clinically silent. Patients have no symptoms during this phase. Following nuclear division, the tissue schizont undergoes cytoplasmic division to produce thousands of merozoites. Shortly thereafter, the infected hepatocyte ruptures, releasing these merozoites into the bloodstream where they infect erythrocytes, beginning the symptomatic phase of infection. Here's something crucial for P. vivax and P. ovale. Some sporozoites don't immediately develop into schizonts but remain dormant as hypnozoites in liver cells. These can activate months or even years later, developing into tissue schizonts that release merozoites. This explains the relapses characteristic of vivax and ovale malaria, occurring long after the initial infection and even after apparent cure. This is why these species require special treatment to eliminate hypnozoites. The merozoites produced in the liver are released into the bloodstream where they infect erythrocytes, beginning the blood stage that causes all clinical symptoms. Merozoites are small oval forms that attach to specific receptor molecules on the erythrocyte surface. These receptors are species-specific, explaining why different Plasmodium species prefer certain cell types. P. malaria infects mainly older erythrocytes. P. vivax and P. ovale prefer young cells called reticulocytes. P. falciparum is the least selective, infecting both younger and older erythrocytes. This lack of selectivity allows high parasitemia levels, contributing to its severity. Following receptor attachment, merozoites penetrate into the erythrocyte, where they're enclosed in a parasitophorous vacuole. A Plasmodium parasite that has recently infected an erythrocyte appears ring-shaped in Giemsa-stained blood smears. You'll see a thin cytoplasmic rim with a dark stained nucleus at the periphery. This classic ring appearance is similar in all four major Plasmodium species during early infection. The ring forms then develop into trophozoites and eventually schizonts, which feed on glucose and hemoglobin within the red blood cell. The digestion of hemoglobin produces hemozoin pigment, the brown or black material you see accumulating in mature parasites. The schizont undergoes multiple nuclear divisions to produce merozoites. The number varies by species, ranging from 6 to 36 merozoites per schizont. When the schizont matures, the infected erythrocyte ruptures, releasing merozoites into the blood plasma. These merozoites immediately infect other erythrocytes, beginning new asexual cycles. After a short initial phase, These schizogonic cycles recur at regular, predictable intervals. The cycle timing is species-specific and explains the fever patterns: 48 hours for P. vivax, P. ovale, and P. falciparum, and 72 hours for P. malaria. Fever is induced when schizons burst, and many red blood cells are destroyed simultaneously, releasing parasite antigens and hemozoin pigment. This triggers cytokine release, causing the typical intermittent fever attacks called malarial paroxysms, the classic periodic fever pattern that helps distinguish malaria from other infections. After one or more schizogonic generations, some parasites in each generation commit to sexual development instead of continuing asexual replication. These develop into male microgamonts, or microgametocytes, and female macrogamonts, or macrogametocytes. These sexual forms persist in the bloodstream for species-specific periods, only 1 day for P. vivax, but up to 22 days for P. falciparum. If not taken up by a blood-sucking female Anopheles mosquito during this time, the gametocytes die. However, if ingested during a mosquito blood meal, they continue development in the mosquito, perpetuating transmission. This is why patients with gametocytes are infectious to mosquitoes, even if they're receiving treatment for their symptoms. When gametocytes are ingested by a female Anopheles mosquito during a blood meal, they undergo sexual development in the mosquito midgut. The change in temperature and pH triggers this transformation. Each microgamete rapidly develops into multiple flagellated microgametes, the male sex cells. Simultaneously, the microgamete transforms into a single macrogamete, the female sex cell. Fusion of a microgamete and macrogamete produces a zygote, which becomes motile and is called an ookinet. This ookinet is the only diploid stage in the entire life cycle. The ookinet penetrates through the midgut epithelium and occupies the space between the epithelial layer and the basal membrane of the mosquito gut wall, where it undergoes morphological transformation into an oocyst. Inside the oocyst, extensive nuclear proliferation occurs, producing thousands of sporozoites through a process called sporogony. This takes approximately 10 to 21 days depending on temperature and species. When mature, the oocyst ruptures, releasing sporozoites into the mosquito's hemolymph, the insect equivalent of blood. The sporozoites then migrate through the mosquito's body cavity to reach the salivary glands, where they accumulate. From the salivary glands, sporozoites can be transmitted to a new human host during the mosquito's next blood meal, completing the life cycle. A single infected mosquito can remain infectious for its entire lifespan, transmitting malaria to multiple people. The classic malarial paroxysm consists of 3 distinct stages. First, the cold stage involves shaking chills lasting 15 minutes to 1 hour. Patients feel intensely cold despite rising body temperature. Second, the hot stage features high-grade fever reaching up to 41 degrees Celsius, lasting 2 to 6 hours. Finally, the profuse sweating stage occurs as fever subsides over 2 to 4 hours, leaving the patient exhausted. However, it's crucial to note that P. falciparum often doesn't follow this classic pattern. Instead, patients may present with continuous high fever without the distinct stages, making diagnoses more challenging and emphasizing the importance of considering malaria in anyone with fever and appropriate travel history. All the characteristic features of malaria result from erythrocytic invasion by the parasites. The 4 major pathogenic mechanisms are fever, anemia, circulatory changes, and immunopathologic phenomena. Understanding these mechanisms helps explain both the clinical presentation and the potential complications, particularly in falciparum malaria. Each mechanism contributes to the overall disease severity, and in P. falciparum infections, these can combine to produce life-threatening complications like cerebral malaria and severe anemia. Fever is the hallmark of malaria and is initiated by the rupture of infected red blood cells that liberates a new generation of merozoites. This is called sporulation. When erythrocytes burst, they release not only merozoites but also hemozoin pigment, parasite proteins, and red blood cell debris. These products act as toxins that induce macrophages to release pro-inflammatory cytokines, particularly tumor necrosis factor, interleukin-1, and interleukin-6. These cytokines act on the hypothalamus to increase body temperature. The synchronized rupture of infected cells at regular intervals explains the periodicity of fever every 48 or 72 hours depending on the species. This periodic fever pattern is a distinctive feature of malaria. Anemia is a major feature of malaria, particularly in severe and chronic infections. Multiple mechanisms contribute. First, parasitized erythrocytes are destroyed either when schizons rupture to release merozoites or when they're phagocytosed by an activated reticuloendothelial system in the spleen and liver. Additionally, there's depression of bone marrow function, reducing new red blood cell production. Sequestration of erythrocytes occurs within the enlarging spleen, effectively removing them from circulation. Remarkably, even non-parasitized red blood cells show accelerated clearance, possibly due to immune-mediated destruction or alterations in cell membranes caused by circulating parasite products. All these mechanisms combine to produce the severe anemia seen in malaria, particularly in children, and during falciparum infections. Circulatory changes are particularly important in falciparum malaria and can lead to life-threatening complications. The high fever causes significant vasodilation throughout the body. In falciparum malaria, this vasodilation leads to decreased effective circulating blood volume and hypotension, which may progress to shock. P. falciparum has a unique ability. Infected erythrocytes express proteins on their surface that cause them to adhere to endothelial cells lining visceral capillaries. This is called cytoadherence, or sequestration. The intense parasitemia combined with this sequestration can severely impair microcirculation in vital organs. This precipitates tissue hypoxia, lactic acidosis, and hypoglycemia. Although all tissues are affected, the brain is most intensely involved, leading to cerebral malaria, one of the deadliest complications. This diagram illustrates the critical process of cytoadherence in falciparum malaria. Infected red blood cells express parasite-derived proteins called PFEMP1 on their surface. These proteins bind to receptors on vascular endothelium, causing the infected cells to stick to blood vessel walls, particularly in deep capillaries of organs like the brain, lungs, and kidneys. This sequestration serves two purposes for the parasite. It prevents infected cells from being filtered out by the spleen, and it provides a microenvironment for parasite maturation. However, for the host, sequestration blocks capillaries, reduces blood flow, and causes tissue damage. The sequestered parasites also trigger local inflammation, further compromising organ function. This is why you rarely see mature stages of P. falciparum in peripheral blood. They're hidden in deep tissues. Cerebral malaria represents a catastrophic immunopathologic complication. Tumor necrosis factor levels increase proportionally with parasite density, and high concentrations appear harmful rather than protective. TNF upregulates endothelial adhesion molecules like ICAM1, E-selectin, and VCAM1, which increases the sequestration of P. falciparum-infected erythrocytes in cerebral vascular endothelium. Alternatively, excessive TNF levels might precipitate cerebral malaria through direct metabolic effects, inducing hypoglycemia and lactic acidosis that impair brain function. The combination of mechanical obstruction from sequestered parasites, local inflammation, and metabolic derangements leads to cerebral edema, seizures, coma, and potentially death. This explains why cerebral malaria has such high mortality. Even with treatment, the damage involves multiple mechanisms. Plasmodium knowlesi deserves special attention as an emerging zoonotic infection. It's naturally transmitted from macaque monkeys to humans by Anopheles mosquito bites, with the first human case reported from eastern Malaysia. It causes severe malaria with a high fatality rate if treatment isn't initiated promptly. The severity relates to P. knowlesi's unique 24-hour erythrocytic cycle, the shortest of all Plasmodium species, allowing extremely rapid parasite multiplication and high parasitemia levels. It can also infect red blood cells of all ages, contributing to high parasite burdens. Diagnosis is challenging because early trophozoites resemble P. falciparum ring forms, while later band forms mimic P. malaria. PCR is the only reliable means of identifying this emerging species, which is increasingly recognized in Southeast Asia. Laboratory diagnosis of malaria relies on several methods. Peripheral blood smear examination using thick and thin smears remains the gold standard, typically stained with Giemsa, Leishman, or Wright staining. Antigen detection tests identify specific parasite proteins, histidine-rich protein 2 for P. falciparum, and lactate dehydrogenase present in all species, using rapid immunochromatographic or lateral flow assays. Serology detects antibodies by ELISA, but is primarily used for epidemiologic purposes rather than acute diagnosis. Molecular methods, particularly PCR, provide the most sensitive and specific diagnosis, especially for species identification and low-level parasitemia. Each method has advantages and limitations in different clinical settings. Malarial parasites can be demonstrated in stained smears of peripheral blood in all symptomatic patients. Both capillary and venous blood can be used to prepare thin and thick smears, typically stained with Wright or Giemsa stains. Thin smears preserve red blood cell morphology, allowing detailed examination of parasite morphology to differentiate species. You can see the size of infected cells, presence of stippling, and detailed parasite features. Thick smears are prepared by lysing erythrocytes with water before staining, which concentrates the parasites. This makes thick smears much more sensitive for detecting very mild parasitemia and excellent for screening. However, species identification is challenging in thick smears due to the distorted appearance. In practice, thick smears screen for parasites, and thin smears identify the species. Rapid diagnostic tests detect specific malarial antigens and can be performed under field conditions within 15 to 20 minutes. The HRP2 test detects histidine-rich protein 2, a protein excreted specifically by young trophozoites of P. falciparum. This test has sensitivity exceeding 95% for falciparum malaria and is extremely useful in resource-limited settings. The lactate dehydrogenase test detects PLDH, an enzyme present in all Plasmodium species. Pan-specific LDH tests detect any malarial infection, while species-specific tests can differentiate between P. falciparum and non-falciparum species. These rapid tests are invaluable where microscopy expertise is limited, though they cannot quantify parasitemia or assess treatment response as effectively as blood smears. This image shows a typical rapid diagnostic test cassette. The test displays multiple lines: a control line that must appear for the test to be valid, an HRP2 line specific for Plasmodium falciparum, and a pan-specific LDH line that detects all species including P. vivax, P. malariae, and P. ovale. If only the pan-specific line appears, it indicates non-falciparum malaria. If both lines appear, it suggests falciparum infection, possibly mixed with other species. These tests are read visually within 15 to 20 minutes and require minimal training. Serologic tests detect antibodies against malarial parasites using ELISA or other immunoassays. However, antibodies take time to develop and persist long after infection is cleared, so serology cannot diagnose acute malaria. These tests are used primarily for epidemiologic purposes, screening blood donors, surveillance studies, or confirming past exposure in return travelers with suspected malaria. DNA detection by PCR can identify different Plasmodium species with extremely high sensitivity and specificity. PCR can detect parasitemias as low as 1 to 5 parasites per microliter, far below the microscopy threshold of 50 to 100 parasites per microliter. PCR is especially useful for confirming species in mixed infections, identifying drug-resistant strains, and in research settings. PCR for confirmation and species determination is indicated in specific situations. First, when patients present with clinical symptoms strongly suggesting malaria but no parasites are visible on blood film microscopy, this could represent very low parasitemia or recent antimalarial treatment that reduced parasite levels. Second, in mortality cases where confirming the diagnosis is crucial for public health reporting and understanding disease patterns. Third, in cases where microscopic appearance suggests P. malariae, which can be confused with P. knowlesi since P. knowlesi has a much more severe course, accurate species identification is clinically important. PCR is also valuable for detecting mixed infections and identifying drug resistance markers. Prevention of malaria requires multiple strategies. Mechanoprophylaxis focuses on reducing mosquito contact. In endemic areas, house screens prevent mosquitoes from entering living spaces. Insecticide bombs can be used within rooms before sleeping, and insecticide-impregnated mosquito netting around beds provides excellent protection during the night when Anopheles mosquitoes feed. For those who must be outside from dusk to dawn, the peak feeding period of Anopheles mosquitoes applying insect repellent containing DEET and wearing protective clothing with long sleeves and long pants significantly reduces bite risk. These simple mechanical measures can substantially reduce malaria transmission, especially when combined with other prevention strategies. Chemoprophylaxis involves taking antimalarial medications to suppress clinical manifestations of infection. A weekly dose of chloroquine provides effective prophylaxis in areas where chloroquine-sensitive parasites predominate. However, in areas with chloroquine-resistant strains, particularly P. falciparum, alternative agents must be used. Mefloquine or doxycycline are usually preferred, though the choice depends on the specific resistance patterns in the travel destination and individual contraindications. The RTS, Vations Parin vaccine, commercially named Mosquirix, represents a major advance. This recombinant vaccine fuses regions of P. falciparum circumsporozoite protein to hepatitis B surface antigen, adjuvanted with AS01 to enhance immune response. Since October 2021, WHO recommends its broad use among children in sub-Saharan Africa and regions with moderate to high P. falciparum transmission. It's administered in 4 doses with a specific schedule and reduces clinical malaria by approximately 39% and severe malaria by approximately 30% over 4 years, a significant public health achievement.